Welcome to our conversation titled Co-Designing Compassion in Digital Healthcare. In this episode, we have two brilliant scientists, both AMS Fellows in AI and Compassion, discussing how important compassion is in the co-design of digital care, allowing for buy-in, ownership, and engagement for patient, provider, and community alike. Carolyn Steele-Gray is from Toronto's Bridgepoint Laboratory for Research and Innovation at Sinai Health, and is also a Tier 2 Canada Research Chair in Implementing Health Innovation. And Mike Lovas is the Director of Design and Innovation at Cancer Digital Intelligence, Princess Margaret Cancer Centre at UHN. Mike brings the unique perspective of both scientist and cancer survivor to his innovative work.
Dr. Carolyn Steele-Gray. I'm a scientist at the Bridgepoint Laboratory for Research and Innovation as part of Sinai Health in downtown Toronto. I'm a 2020-2021 AMS Healthcare Fellow in Digital Health and Compassion. I'm also an assistant professor at the Institute for Health Policy, Management and Evaluation in the Dalla Lana School of Public Health at University of Toronto. And I also hold a Tier 2 Canada Research Chair in Implementing Digital Health Innovation. Lots of my work focuses on how we build, implement, and evaluate technologies that can support primary care and integrated models to help us kind of transform our system to be more seamless and better supporting for the patients who need it most.
So my name is Mike Lovas. I'm the Director of Design and Innovation at Cancer Digital Intelligence at Princess Margaret Cancer Centre at UHN. I am a 2021 AMS Healthcare Fellow in Digital Compassion. Yeah, I guess a bit of my background, I started in biomedical engineering and then shifted into design. And my previous role before this was working at a really top-notch healthcare usability and design consultancy called Healthcare Human Factors, working on a variety of different projects across the healthcare setting. But then in 2018, I actually got diagnosed with cancer. And so I had the opportunity, I guess, to see things from the other side of the gurney. And it was a real kind of eye-opener for me, even though things went well and the treatment went really well, really smooth recovery in the end. The beginning of the journey was really challenging for me. And so I just had this opportunity to really dig deep into the work that I was doing and try to think of ways to push things in a positive direction. And so, long story short, I ended up partnering with some great people at Princess Margaret, Ali Berlin, radiation oncologist, to start a new innovation program to start looking at how we can rethink how cancer care is delivered. That started a little bit before the pandemic, and we've been going strong ever since.
I'm interested about how both of us kind of came to the notion of compassion. I wonder if maybe I want to hear from what you think first, because you can think about compassion in these two very different ways, right? From your experience kind of as a leader in the system as well as like a patient. So how do you think about it in those two different perspectives?
Great question. I think compassion for me as a patient was really about getting the support and the help that I needed when I needed it, regardless of where I was in my journey. I think I struggled a lot with being in between silos and not knowing exactly who to talk to about what issue I was having, whether it was kind of anxiety or navigational or symptom related. And so compassion to me is really, from a patient perspective, is really about being able to get in contact with the humans on my care team to get the kind of answers or support that I needed in the right time. Yeah, I feel like from a leadership perspective, I feel like it's a similar thing. Patients grapple with the same kind of issues, the same like challenging processes and silos. And then on the provider or the staff side, I feel like they deal with the same kind of challenges as well. And so I think really elevating the experience of patients, but also our providers and staff is what we're trying to do and what we're trying to focus on. What about you? How's it coming across on your side?
Yeah, it's so interesting because like hearing you kind of reflect on it from both those perspectives really reminds me of what we've been learning in in co-designing technologies and how I've come to think about compassion because of the experience of doing that. We started trying to build something that was person-centered. And we came at that question in a way that we were like, well, we're going to collect a bunch of symptom data that's about symptoms that are really important to patients. And that's going to really make us better at caring for patients and really understanding their needs and being able to address their needs. And, if we think about how we define compassion as being the identification of suffering and then doing something about it. So we thought, okay, let's pick up on symptoms and that's going to help. And I guess I'm sort of jumping the gun into our co-design point next, but I think for me, they're so intertwined. And so I hear you saying it was about being seen and making connections to people. And I feel like it was co-designing that allowed us to see that exact experience because we were early days designing a technology in primary care. And we had been building this basically symptom monitor that we were picking up symptoms people told us were really important to them. But there was this moment in a session where it was so clear that that wasn't what was important to them. That wasn't what they wanted to share about themselves. That wasn't how they wanted to be seen in primary care. They wanted to be seen as like an entire person that wasn't just their grouping of symptoms. They wanted that human connection to know where they were going, to not be siloed out and be seen in their entirety, and for the technology to reflect that. And we had completely missed our understanding of what the challenge even was and what it meant to be person-centered to allow us to be compassionate. And if we hadn't been doing co-design, we never would have seen that connection. So I hear your reflection is just so similar to not just that study, but so many studies that we've done and read about.
Yeah, that made me think of some of the patient interviews that we've been doing, that depending on the context and where patients are and what their kind of needs in the moment are, it seems like compassion, like we're really focused on remote care. So helping support patients while they're outside of the hospital, because that's ultimately where, at least in cancer care, that's the majority of their lives are spent outside of the cancer center. And so what we've been hearing from patients is, depending on where they are and what their needs are, compassion can look like something completely different. It can be, give me an answer to my question or my concern as quickly as possible in the most efficient way possible. And so that leads us very nicely to technology. Whereas in other cases, when patients are struggling with kind of anxiety or emotional, psychosocial things, I agree with you that they want more human connection. And so it's a really nuanced understanding of what the needs are and when and how we can best support those. Very similar to the things that we've been hearing in our interviews with patients and caregivers is around this notion that compassion in remote cancer care, and that's what we're focused on, is trying to support patients while they're outside of the cancer center because that's where they spend most of their time. It's a really nuanced view where sometimes, depending on the need, patients want a transparent, trusted response as quickly as possible in the most efficient way as possible. And that's what compassion looks like to them at that moment. Whereas in other times where maybe it's more anxiety or psychosocial or existential, that's where like the real kind of classic human connection piece kicks in. And I would say physical symptoms might be somewhere in between, where they want a trusted response to their symptoms by somebody on the care team that they feel like has, enough knowledge with their case and with cancer care, but in the most immediate way possible.
I love that reflection because you kind of show the variety of ways in which technology can kind of address this and how it's, as you say, like contextual and like personal to people and what it is that they're looking for in making those connections and where technology sits. It's kind of like any service delivery. One size does not fit all. And, technology is no different. I guess we see that so much when we're doing co-design work, right? You have this group of people and maybe multiple groups of people coming in with different perspectives, and you see this kind of very broad experience that they're trying to share with you and how they envision what that problem is that they're trying to solve and the different kinds of solutions they see to it. which align with those kind of different things that people want that you're seeing in your own work. So I think one of our jobs today is to talk about what co-design is.
The kind of, theoretical or foundational aspects of co-design, how I see it, is mostly coming from the service design world or human-centered design world. And so there's lots of different names out there for co-design, participatory design, collaborative design. Co-design to me is really this broad idea of involving users or stakeholders, in our case, patients, caregivers, providers, staff, in the creation of a new thing, whether that be a product or a service. People have different takes on what the kind of intent of that work is, whether it be like getting really specific feedback on something like idea generation or usability testing feedback on a product, or getting broad perspectives from representative users or representative patients. And then others take a kind of an equity lens or a justice lens to attempt to hear voices from people who are underrepresented in this kind of engagement, or specifically to improve access or healthcare to people who are underserved in the current system. We like to kind of pair qualitative and quantitative methodologies. A lot of semi-structured interviews, observations in the clinics or at homes with patients, lots of different workshops, visualization, kind of mapping activities, usability testing. And then some of my, favorite things are to do service prototyping, which is basically the idea of mocking up a new service, whether it be, intake into a clinic or setting up virtual care, mocking it up with as much detail as you can, as quickly as you can, and then actually running real patients and real staff through scenarios to see how they experience it in real life. And then other things like surveys and looking at user analytics and really pairing the data, like the qualitative data with the quantitative data, I think is really powerful.
Oh, yeah. Going through the service model testing sounds like super fun.
Yeah.
Being able to actually walk people through that. Gosh, and so much learning out of that. It's so interesting kind of hearing also the different purposes that you say, like different folks will come at it from these different purposes. When I think about it, I imagine, what I've read from some of like the foundational work is that those different purposes are all there. They're kind of part of the life course of co-design. Those different components happen at different stages. So the early ideas generating is like really early on, and then you move on to some beta usability testing, and then you move into the scenario work, and then you move into kind of more regular piece. And the thing that I always found foundational about it, and I think it underlines a lot of what you've kind of shared with us and using the different methods and how to kind of elicit this, is the notion of where creativity kind of sits. And Sanders and Strappers does a really nice job of this in like their foundational work in 2008. I feel like I've bored you with this anecdote so many times that, they tell us that creativity doesn't just sit with designers, that it comes from different places. And when you open the opportunity to see that users of all different stripes are going to have different ideas about what the problem is, what the solutions can be, and how we work together to solve them, you open up this wonderful box of ideas that were never there. And I've shared the same anecdote in presentations before. It reminds me of a story of many years ago. I was invited to lead some co-design work for a colleague developing some educational platform for some providers. And they were working with a tech company. And the first thing I said was like, well, we need to co-design this thing so that it makes sense. The tech partner was like, well, and I might butcher this, but the old Henry Ford adage, if you ask people in the 1800s how you'd go faster, they wouldn't have built a car. They would have built a faster horse and buggy. And I feel like that anecdote misses the point of co-design all entirely, that you're not going out and asking specifically what we're building. You're going out and discovering what's meaningful to people. And all of those different stages and purposes that you described are just like different ways of understanding what's like meaningful and sensical and purposeful to people at those different design stages. And I remember going through the co-design process. We had the tech guy kind of like sitting in the room with us for a couple of the sessions. And all the participants left, and I had a conversation with the master student I was working with about what we had learned and what that meant. And he kind of sat back and was like, okay, I get it now. And it was like such a nice turning point for this partner who's like now a good friend, having gone through that process. It's interesting because like, regardless of where you're at in those stages you've talked through or the methods that you're using, at the end of the day, they're about kind of bringing creativity forward and understanding, I think, what meaningfulness is, or at least that's how I kind of think about it.
I think I agree wholeheartedly. I think there's this tension, and in my last role, there was a lot of debate over what's the role of the designer versus, whatever, anyone else. Designers have a very, there's lots of different types of designers. There's visual designers, there's UI, UX, or digital product designers. There's physical, industrial designers that make physical things. And I think in our setting, and then service design is another bucket. And I think in our setting, those specific types of designers do play roles. When you're building a app or a website, like being able to quickly mock something up and make it usable and stuff, that there's like a very specific skill set that quote unquote the visual designer, UI UX designer has in their tool belt. But when you're talking about kind of high level service design, I feel like the role there often is kind of holding space, bringing people together, helping visualize or make things that are kind of obscure or opaque to other people in the department or in the system, making it very visible and clear to everyone. Like, this is the current state of things in the patient journey, let's say, or in the workflows of staff, and helping bring people together to understand what the system is currently, and then helping facilitate or hold space for people to come up with their own ideas for how things should be done in kind of an ideal state or the next step towards some ideal state. And so in that way, I feel like I totally agree that all the folks in the room, regardless of what their profession is or background or training, they are the ones who ultimately come up with the big ideas on how to drive things forward, which kind of makes sense. Like, they live this day in, day out. And so the job of the designer or facilitator is really to prompt people, to get them in the right mindset and get them physically or virtually in the same room to help those insights and ideas come to life. And yeah, I've seen great ideas come out of people who are like, oh yeah, I can't draw, I'm not creative at all, but they have the kind of in-depth knowledge to make kind of new, great ideas come to life.
I love that conceptualization of the role of a service designer, because I don't know that everyone thinks about it that way, right? That people, when you hear the word designer, they come to a very traditional notion of like someone who can draw or someone who can create in a very different kind of way. And you're describing it as holding space so that you can hear what makes sense to people and what's meaningful to people. I think that's such a powerful way of thinking about the role of service design, and elevates it to a really important place in how we think about not just technology, but health system transformation really broadly. Because we're not good at holding space for different ideas, right? We create structures and processes and ways of working. And, we necessarily need to kind of follow that, especially in, rapidly changing environments. But that role of holding space, I think, needs to be kind of paid more attention to, and gives us the space to ask questions about, is what we're doing compassionate? And does this technology even make sense? And what problem are we even solving? And those types of challenging questions.
I've had this debate many a time, but I think actually now, reflecting on my current team and the skill sets that are at the table, I feel like we've shifted from the service designer kind of owning the activities to everyone kind of taking on a service mindset and kind of an agile service design mindset, which is really kind of, to what you were just saying, are really around being fluid and dynamic and trying to create new services for our patients and our staff, and then supporting it with technology.
Please check out the new AMS Healthcare series, produced in partnership with Healthy Debate, focusing on solutions-based articles, examining gaps in our healthcare system. We hope the series fosters an open-ended discussion on how lessons learned can enhance the delivery of high-quality, compassionate care. Go to healthydebate.ca. And now back to our conversation.
So yeah, this multidisciplinary team, I think, is a really important feature of this work as well. Being able to understand the potential and possibilities of technology, understanding the clinical context, understanding the patient experience, the patient journey, understanding data architecture and data infrastructure, and then really, if we can highlight or elevate the service, like really providing value to patients over time, and similarly, providing value to clinicians and frontline staff over time, holding those things up, I think there's a lot of power that we can bring to the table.
Yeah, that multidisciplinary lens is so crucial, right? That you're not just like taking on one view, but you have like a view from different types of professions, from different types of backgrounds to kind of unpack that problem. And I think that kind of leads into one of the things we wanted to get to today too, around who is involved. So we talk about it from like a broad standpoint. One of my wonderful colleagues out of the University of Auckland pointed me in this direction when we were writing a chapter on this together, Dr. Tim Keneally. And he likes to think about users. He does technology in New Zealand and in primary care transformation. And he likes to think about users in kind of like three tiers. First is your primary user. That's the person like touching the technology. Next, you have your secondary user, who is the person kind of like supporting the person touching the technology, maybe somebody like a family caregiver who's helping a patient on a mobile device or something like that. But then really importantly for him, and I think we're seeing increasingly if we're talking about equity, is the tertiary user, being like the broader community that may not touch the technology, but may be influenced or impacted by it. So, the classic example there is if you put a new scheduling system online so that people can access their provider, if there's a swath of individuals within your community that don't have access to that technology for whatever reason, you've created a very important barrier to access to the tertiary user. So I tend to think about it in those levels. How do you kind of think about who was involved in co-design? You talked about like the broad kind of interdisciplinary team, but who else would you kind of define as a user or a partner?
Personally, I like to see the orientation of all of this kind of work starting with the patient journey. And in cancer, especially, I think the caregiver or family or loved ones are really important stakeholders because they're often, doing a big, heavy lift in terms of supporting the patient through cancer care. Again, from kind of a service design lens, we see that side of the table really important, but then almost or maybe even equally as important is the providers and the frontline staff who are actually delivering the service. And so that's often frontline staff, nurses, doctors, allied health, administrative staff, and then also people who are kind of in the background, if you will, who don't necessarily have direct interface with the patient. In a previous project, we did a decent amount of work with the people in the back of the clinic who, this is a few years back, but doing the paper charting. So people who are taking the paper charts, filing them, sorting them, faxing them off. And so we worked with them to understand their workflows and how their work actually impacted the whole service. I think a lot of times if we take a kind of a product approach to this, we can really hone in on the core end user, which in our case might be the patient. But again, from a service perspective, we kind of elevate all sides of the service because we know that if there's a happy provider or a content or satisfied provider, they're likely to provide better service. And kind of an underappreciated version of that is vice versa, where the patient who's hasn't had to wait all day and isn't frustrated with the service up to that point will actually probably be a better patient for the physician. So holding both sides up is really important.
Gosh, the AMS healthcare book talks about that, right? That compassion similarly needs to be thought of in both ways in order for it to be meaningful and perpetuated over time. So here's something I struggle with, and I wonder what you think about it, Mike. These are two very different groups, that we work with. who have really, and not just two, but like we're talking patients and their families and communities and providers and administrators and decision makers and funders. All these folks have really different purposes and aims and goals for what they want a particular service or health system to look like. It's hard to reconcile those different things. And I feel like I've asked this of every designer I've ever talked to, because we struggle with balancing the needs of those folks. And I think like you, we try to like really say, well, the patient is our first point, and making sure we're meeting that need is kind of our North Star as we go through. But then you can kind of come to some real sticky points with how that actually looks like on the ground and how you meet that need alongside other needs. I wonder if that's a challenge you've struggled with.
Yeah, for sure. I mean, there's always a lot, like as you do co-design and you're opening yourselves up to understanding different viewpoints and different perspectives and hearing lots of voices, I think a really important role is to synthesize all of that data and analyze it and do something with it. I think action is the most important part of this whole thing. So yeah, that it is a challenge. And so part of it to me is really around setting an early vision for the work and being really clear on your goals as a group, which should be informed with patients and providers and frontline staff, et cetera. But once you have that kind of North Star of what you're shooting for, I think it becomes, it's not easy, but it's a lot easier to keep things moving in a forward direction. And that's not to say that things don't meander and the ideas don't shift directions, but if you're always pointing back and reflecting on what the North Star is, I think it can be really powerful. I think part of that is being clear on, are you trying to create change? Like, what's your primary objective? Is it around making care better for, cancer patients, for instance? Or is it to create a research study to generate knowledge for the scientific community? Or is it efficiency, for instance? And so those things don't have to be mutually exclusive, but prioritizing, we are working on driving care to create better care first. And then those other things are secondary. I think that's the way that we've kind of approached it, where we will generate evidence and research output from our work, but our North Star is about creating better care for patients right now.
That's a really powerful coalescer, I guess, of disparate directions. And I think we see that as well in some of the more successful health system transformations, even from a broader sense, not just technologically enabled, but transformations in a broader way. One of the studies we did in the last few years was not so much, it came from technology, but it ended up more being in the service design space, was around goal-oriented care. And one of the things we found, so goal-oriented care is a particular approach to person-centered care delivery, right? Where the service you deliver and the care plans you set are about what the patient goal is, or what's most meaningful to the patient, what they want to achieve in their lives, not just about kind of their care delivery. And what we found was like that as a North Star coalesced huge disparate amount of like providers from very different lenses and as well as administrators and funders in a couple of the cases that we looked at internationally. So I think that it's interesting because I hear this a lot, the patient need is a wonderful kind of coalescer because it's kind of also what brings everybody to healthcare in the first place. They want to help people. And I wonder about compassion being that as well, right? Like I wonder if the drive toward being more compassionate to others and seeing more compassion come back to themselves as providers might be one of those. Maybe that's a useful North Star in how we co-design technologies as well as new services. I wonder what you think about that, as I just thought of that in this moment.
Because we're early days in our work around compassion as a formal idea, I think a lot of our work is fundamentally compassionate from a variety of different perspectives. Early signals really point to this idea of a nuanced idea of what compassion looks like for different people at different times. I think it resonates really strongly with people when we ask them about compassion, either from the patient or the provider side. But again, they have very different understandings of what that means to them. And so, yeah, I think it's an interesting idea. I think it does speak to pretty much everyone that we've interviewed or talked to, but it's not one thing. So I'm curious to see how it is a thing to coalesce around.
Oh gosh, it always comes back to sense making, not to always bring it back to complex adaptive systems theory, as I seem to in many of our conversations. Gosh, in that theory, sense making is this foundational component of any transformation, that you need to know what it is you want and what it is the people around you want. And we've seen this in so many studies, and we've written about it in our own teams, that people get stuck in this sense making thing, right? And if you have an idea that on the surface makes sense and can group people together, like an idea like delivering compassionate care, or person-centered care has that too. But then you dive in and people define it in different ways. And that's where I think things get really tricky about how you operationalize the concept. And we saw this with person-centered care. We saw this with goal-oriented care. I mean, going back to my PhD work, I was doing work on accountability, and my interviews had to start with asking people how they defined accountability. And I got 20 different answers. And then we did the same thing with our goal-oriented care study, and we got a lot of similar answers, but different kind of ways of coming to it. But like, people define these ideas differently, and I'll be so curious to see how it's coming out in your work for your fellowship, Mike. But I wonder too, if maybe the activity of defining and working on that definition together as part of the process might be one of the activities that co-design allows us to do, right? That's part of the meaningfulness and sense-making work. And if it gets kind of imbued in the work that we're doing, then what we're designing and creating is around this consistently co-created idea of what compassionate care delivery is and how technology can enable that.
Yeah, I mean, that's one of the goals of my AMS Healthcare Fellowship, is around, we're doing all this work in cancer care, specifically remote cancer care, so supporting patients between their visits while they're outside the cancer center. And one piece that we're trying to elevate out of this is around kind of general principles for how to make good, compassionate remote cancer care. And we're looking again at both sides, the patient and caregiver side and the provider and staff side. And we're starting this work with this kind of foundational, or what I see as foundational, which is creating a kind of a one-stop shop for patients if they have any questions or concerns or symptoms while at home. We're making it this one-stop shop so that they can dump their questions, queries, concerns into a single place, and then we will do the hard work to figure out who it needs to go to. In doing this work, we're going to tease out a lot of principles in terms of how to deliver this kind of humane or compassionate remote care for this foundational work, but then we're going to be able to apply that, or the thinking is that we're going to be able to apply that to other work around remote patient monitoring and delivering care at home. And so this is kind of early foundational work that hopefully will plant some big seeds.
Yeah, I think that's really exciting for a couple of reasons, right? Because it's doing development work that isn't just about the technology you're building and then scaling and spreading like a product. You're digging into the process through which you're doing it, and whether you can embed this idea of compassion into a process that can then be scaled and spread to other places, right? And that's a different way of thinking about transformation, not just from here's a service or here's a product and off it goes, and we're going to transform the system that way. It's more that here's a process that we can follow, and here is a way to understand the care that we're delivering. And, co-design does that too. It's a process through which we engage in transformation that can be scaled and spread and adapted to different contexts. But the foundation you're setting or suggesting is that we can think about compassionate care as embedded as we would like person-centeredness, as a driving value of the process that we're putting in place to allow for that transformation, that new technology or that new model to kind of come forward. And I think that can be often like a missed innovation. We always talk about like products and technologies and like the fun, shiny stuff, but I don't know. I think process can be innovative, and the way we think about doing our work and the way we do our transformation itself can be an innovation that we can be sharing broadly. It'll be really neat to kind of unpack some of those process-oriented findings from the work that you're doing with your AMS Healthcare Fellowship as well.
Yeah.
Thanks, Mike. This is really fun.
Yeah, thanks, Carolyn. As always, great discussion. I'm sure we'll have many more.
Thanks for joining us for this inspiring conversation on the importance of compassion in co-designing digital healthcare. A big thanks to Carolyn and Mike for the great conversation. Please connect with us again for the next AMS Healthcare conversation on good tech, compassionate healthcare.